अगर आपको ये टेस्ट इजी लगा ना तो बहुत अच्छा है. So that's good. That means your preparation is good. I intentionally didn't keep it very difficult. It was medium level, but yes, good. Good job. अगर आपको इस टेस्ट में 75 में से सर्जरी है, not the derma part. I don't know about derma, but if you got out of 75, 60 questions, 60, 65, that is great. Okay, that is great. Then you are on in a good track. अगर थोड़े कम आए 50 or less, then you need to work a little hard. And my only message is keep solving, solving, solving. The way forward is by solving. The more you solve, the better it is. Okay. So 60 range is the right way to go. So let's start solving now. Okay. Let's start. Today, some questions we will discuss. Most of the questions you should be knowing by yourself. So let's start. So 45-year-old lady presents to the ER with RTA. Pulse is high, BP is low, JVP is elevated. Right. So JVP is elevated. Left side is normal, but right side shows hyperresonance. What is the next step? So what is your diagnosis here? Diagnosis here is tension pneumothorax. Why tension pneumothorax? Low blood pressure, high JVP, and hyperresonance, correct? So tension pneumothorax, next step will be needle insertion. So what is the pathway? First do needle insertion so that the tension goes, then do chest x-ray, that will be number 2, and last will be intercostal drain. Okay, so between ICD and needle insertion, first step will be needle insertion. They have asked you immediate next step, right? So answer will be needle insertion, not A. ठीक है, A नहीं होगा. A will be after patient is stabilized. So it's not going to be A. Okay. This question came in one of the FMG papers, so I've put it here. Very nice question. What is this that you see? क्या दिख रहा है इसमें आपको? This is Pringle maneuver. We discussed this in the class also. So this is going to be Pringle maneuver. And where is this done? This is done in liver trauma. Right. Pringle maneuver is done in liver trauma intraoperatively. So during surgery, if liver is bleeding a lot, you will do Pringle maneuver, in which what you are going to do is you will clamp this area, this ligament. And what gets clamped in this area, it's going to be hepatic artery, gets clamped, portal vein. So hepatic artery will get clamped, portal vein gets clamped, bile duct also gets clamped, but that's not the important thing. All right. And when I put this, the bleeding should at least for some time stop. At least temporarily, the bleeding should stop. And then from wherever it is bleeding, I'll take some stitches or do whatever I can to stop the bleeding. But at least temporarily, this will work. Okay. So this is Pringle maneuver. What are all these? Cattle maneuver, Mattox maneuver. We will discuss this. What is all this? Anybody knows? Cattle maneuver, Mattox maneuver. सुना है कभी? Any idea? पता होना चाहिए. No? Okay, so I will tell you. These are also done in abdominal trauma cases. थोड़ा hi-fi है, इसलिए I didn't teach it in class. This is also done in abdominal trauma when I am suspecting aortic injury or IVC injury. So they look like this. It is done in retroperitoneal trauma. So you can add this to your notes later if you want. In retroperitoneal trauma, when I am suspecting abdominal aorta or IVC injury, I do these maneuvers. Basically, when I do enter the abdomen, I can't see where my IVC is. I can't see where the aorta is. So I have to do some moving about the intestines. Intestines को मुझे move करना पड़ता है. I move them and I go behind them because aorta, IVC, as you can see, they are एकदम पीछे, intestine के पीछे. So what I do is, if I want to see the IVC, I will use the right viscera. I will push them. So right side में जो भी intestines है, I push them medially. So right-sided viscera are pushed medially. So IVC देखने के लिए मुझे right viscera को medially करना पड़ता है. This is called as Cattle's maneuver. This is Cattle. If I want to see the abdominal aorta, which is on the left side, left में होती है abdominal aorta, I will do left viscera. medially. So I will medialize the left viscera. This is called as METOX. Okay, so these are the two maneuvers that you should know for reaching IVC and abdominal aorta. For IVC, right viscera medialized, cattle maneuver. For aorta, left viscera medialized, because aorta is on left, this is aorta, IVC is on right. Okay, in the abdomen. So that was little extra information. You can add it to your notes if you wish to. This again was asked last year in FMG. 50-year-old lady with breast lump with Q de orange more than 2/3 of the breasts belongs to, this is going to be T4D. Okay, T4B is going to be Q de orange less than 1/3. This is more than 2/3, so it is going to be T4D. Right, T4D is your inflammatory breast cancer. Okay, it is your inflammatory breast cancer. राइट, तो ये तो इजी था, ये तो पहले भी आ चुका है, तो आई एम श्योर आपको इसका आंसर तो आया ही होगा. नाउ मूविंग ऑन. This is the TNM staging which we have discussed in class. You can see it later if you want. What is this being done here? In which disease is this done? What you see here. कब करते हैं ये? It is done as a part of which procedure? This image that you are seeing. Yes. Excellent, excellent, brilliant. It is a part of BCT, breast conservation therapy. In BCT, I do wide excision. Well, that is one thing, wide local excision. Second thing that I do is sentinel lymph node biopsy. But when do I do sentinel lymph node biopsy? In which patients? This is what I want you to tell me. In which patients of BCT will I do sentinel lymph node biopsy? And the third is going to be radiotherapy. कौन से cases में करते हैं? Vessels affected? No, that's not what I've taught you. Excellent, Dr. Shah. Node negative patients. So sentinel lymph node sampling is done if person is clinically node negative or no lymph node is palpable. If lymph node is palpable, what will you do? If lymph node palpable, what will you do? If node is enlarged, तो क्या करेंगे? तो sentinel lymph node biopsy नहीं करेंगे. Then you will do straight away axillary clearance. Right? Then you will do axillary clearance straight away. You are not going to wait. Upfront, you will do axillary clearance. So that was straightforward, right? Let's move on. Patient presents with head trauma during a rugby game. You know why rugby game? Why is this important? Why have I said rugby? Any reason? He has altered consciousness. CT is showing this nice thing. You know this, very nice. Your favorite thing, E for idli. Why did I say rugby game? Rugby का क्या संबंध है इसमें? है कुछ संबंध? Altered can be SDH, yeah, but the image is showing EDH. So rugby game, because this implies the person had a moderate intensity trauma. Okay, it is moderate intensity trauma. SDH will never happen in moderate trauma. SDH will happen in bad trauma. Okay, road traffic accident, fall from a height, you will get SDH. Even if you have doubt, image tells you it is like this, biconvex like idli, so acute EDH because it looks like idli, or biconvex. How does chronic EDH look? You know how SDH will look, na? SDH will look like a banana. This is how SDH looks. How does chronic EDH look? There is no chronic EDH. Thank you, Prakash. Wonderful. That's what I wanted to hear. ऐसा कुछ होता ही नहीं. Okay, there is no chronic EDH. There is acute EDH. SDH can be either. SDH can be acute or chronic. Chronic SDH will look black. Okay, clear about this? Wonderful. Okay, we didn't discuss this topic, so we will discuss this a little bit. What image is what system is responsible for the limb swelling that you see here? That is this. This is going to be lymphedema. Why is it lymphedema? Why is it not cardiac edema? Banana looks black. Yeah, banana will look black. Absolutely. You are right. Why is it lymphedema? So understand lymphedema happens for two reasons. Either it will be a primary lymphedema. Primary means the lymphatics are damaged without any disease. Okay, there is no disease. Or it will be secondary. Secondary to some disease. Most commonly, it is going to be filariasis. That is the most common cause of secondary lymphedema, filariasis. So why is this not just some edema? Why is it lymphedema? Because there are some typical appearances that you see. You see over here, even the toes are swollen. That is called as squaring of toes. It's a very typical sign. Squaring of toes. The calf that you see also has a typical appearance that is called as tree trunk appearance. It looks like a tree trunk. So ऐसे you get involvement of toes, tree trunk sign. This the dorsum of the foot looks like a buffalo. It is called a buffalo hump. And if I try to pinch the skin, what typical finding do I get when I try to pinch the skin? In this case, pinch करने पे क्या होगा? If I try to pinch the skin, what will happen? So there is a finding. The skin cannot be pinched. So skin not pinchable. That is called as stemmer sign. Okay. So you can make a note of this. That is called as stemmer sign. That is a finding of lymphedema. When the skin becomes very thick, you try to pinch it, it will not get pinched. That is called stemmer sign. Where is this used? So this is a very classical image. This is a Veress needle. Where do you use Veress needle? कहाँ पर use होती है? What is the role in surgery for Veress needle? It is used for starting any laparoscopic surgery. That is called as closed technique of pneumoperitoneum. So the role of Veress needle is in closed technique of pneumoperitoneum. So whenever I start any laparoscopic surgery, I have to first fill the abdomen with CO2. So when I have to fill the abdomen with CO2 before I start the surgery, I take this needle and I put it over here in the abdomen blindly. This area where I put the Veress needle is called Palmer's point. It is in the left hypochondrium. So I put the needle, Veress needle, then I fill it, I attach CO2. It will go in the abdomen and the abdomen will distend. And when the abdomen will distend and CO2 gets filled in it, then I put my instruments, I put my ports and I do the surgery. So this is called as closed technique of pneumoperitoneum, right? Why not Salah needle? This has a typical double tip. इसमें ना tip है ना वो double tip है. So there is a safety mechanism. There is a sharp end like this, and from inside there is a blunt tip which goes like this, which you see over here. वो Salah needle में नहीं है. Then he's asking why CO2? Why should I put CO2, not air? Anybody wants to answer? CO2 में क्या खास बात है? Why should I inflate with CO2? Why not with air, oxygen? It's because CO2, it is non-combustible. But ठीक है, combustion is not what I'm worried about. The problem is a lot of the CO2 which I put in the abdomen will also enter the blood vessels. There is a risk of air embolism. With CO2, it's very less risk of air embolism. Okay, because CO2, every time you will breathe, CO2 will be washed out. So it is very easy to eliminate. Air, oxygen don't get washed out. So they can cause air embolism. So less risk of air embolism. Right? That's why CO2. Questions are good. What is this? This instrument? Trocar. Which trocar? कौन सी trocar है? Which trocar? This is a plastic trocar, also called as optical trocar. It is transparent. It is called as a plastic or an optical trocar. So I can, when I put it, I can put a camera inside it and I can see from inside. That is why it is an optical trocar. I hope you got this question correct. This was a little tricky. मैंने जबरदस्ती ये question डाला. It was to trick you a bit. So I hope you got it right. After resection of lipoma, she developed an elevated scar, which you can see here, but it was non-itchy. And it was within the wound margin. So this is going to be hypertrophic scar. Okay. Keloid will be like this. It will be very ugly looking. I will show you over here. See how keloid looks. It goes outside. So yeah, absolutely right. Keloid is beyond the skin margin. And this, I have told you, it is within the wound. Wonderful. 6-day-old child with bilious vomiting presents with double bubble sign on X-ray. What is the child having? अच्छा डर्मा में भी पढ़ाया था सर ने, बच गया. Dermatology benefit. So the diagnosis here, excellent. This is duodenal atresia. Which patients get duodenal atresia? कौन से पेशेंट में होती है duodenal atresia? Who gets it? Congenital. नहीं. Who gets it? Risk factor for duodenal atresia. It is associated with which disease? It is congenital. Absolutely right. Neonatal. Correct. Child is born with it. Aspirin. Surgery वाला आंसर दो. Aspirin क्या है? No. It is seen with annular pancreas. Patients who have annular pancreas, of course, patients who have Down syndrome. They get it. The treatment is going to be surgical bypass. So wherever there is the obstruction, you have to bypass it. Normally it is over here in the second part of duodenum, D2. So you pull this duodenum over here and you do a side-to-side anastomosis. That is a duodenostomy. It looks like this, your double bubble. Okay, I hope you got this right as well. These kind of questions will come in your exams, so please be ready for it. Yes, ऐसे आएंगे question exam में, एकदम classical है. Following trauma, which injury takes the least time to death? Airway injury. Why is this not the answer? I asked this in class that day. Aorta getting injured does not kill me very fast. How? Aorta does not kill. But how can aorta not kill? Someone messaged me also. I don't know if she's here today. Daksha. She messaged me in my chat. Sir, इसका आंसर तो दो. आपने जवाब नहीं दिया. Duodenojejunectomy is less physiological. DD is more physiological. ये Diksha is here. See Diksha, I remembered. मैंने बताया नहीं, आपने बताया नहीं. I asked you the question. So it's because understand when the aorta injures, no, either the person dies on the spot and doesn't reach the hospital. 50% cases die on the spot. They are not diagnosed. पता ही नहीं चलते. जो बाकी हॉस्पिटल पहुंचेंगे ना, that's because the bleeding has stopped. It stops by itself because of some tissue around it, some natural tamponade, it will block it. So if the bleeding has stopped, these 50% patients reach the hospital. अब तो bleed नहीं हो रहा, तो ठीक है ना. So it gets tamponaded by the tissues in the mediastinum. That's why the person reaches the hospital. Otherwise, he will not reach the hospital. That's why it's not immediate. It will take some time. When he reaches the hospital, you can investigate, identify, then treat it. Yeah. So this I already told you, least time is airway obstruction. Obviously, that's why it is ABCD. Because first it will be airway obstruction, then there will be breathing like tension pneumothorax. This is number 2. Then you have bleeding problems like hemorrhage, cardiac tamponade. Then D will be EDH. This is the order. This is given in Bailey. Airway obstruction, tension pneumothorax, intra-abdominal bleed, EDH. ये Bailey का आंसर है. Tension pneumothorax is second. Yeah. Okay. I want to discuss one topic here. People were asking me, sir, ये topic पढ़ाओ, ये topic पढ़ाओ. So this topic we will discuss here. In which of the following conditions is this instrument not used? What is this instrument? कौन सी instrument है? What instrument is this? Very good. This is proctoscope. So proctoscope is something that is normally used to identify hemorrhoids. Normally used in cases of bleeding per rectum. Normally used in patients with C8 or other anal and perineal disorders. But fissure is also anal disorder. Why not use it in fissure? Fissure में क्या है? Why it is contraindicated? What's the big deal putting a proctoscope? Painful. So remember, proctoscope is contraindicated in painful anal disorders. Why? Why? What will happen if I put it? Fissure is a very painful condition. आप में से किसी को हुआ भी होगा. I am sure you must have had fissures. It's very common. It's because when there is a fissure, the sphincters become very tight. Okay, it's very tight. Finger भी नहीं जाएगी अंदर. If you try to push the proctoscope inside, the patient will get tremendous pain. He will have extreme pain. And the pain is so much, the patient can get a vasovagal shock. So patient लात नहीं मारेगा, वो बेहोश हो जाएगा और वो शायद मर जाएगा. He can die also, heart can stop. But definitely बेहोश हो जाएगा. The pain is so much because of vagal syndrome. Okay. Now come to hemorrhoids. Hemorrhoid is one thing. Hemorrhoids are not painful. No. Hemorrhoids are not painful. Sorry. What are hemorrhoids? Hemorrhoids are nothing but dilated hemorrhoidal veins, which are also called as anal cushions. थोड़ा आपको मैं हेमोरॉइड्स बता दूंगा जो मैंने क्लास में नहीं बताया था. You can add it to your anal canal notes or you can put this separately. So they are dilated anal cushions. What are these anal cushions? Anal canal is like this. Okay, above is the levator ani, and there is a dentate line over here. Over the dentate line, you have your anal cushions. होते हैं mucosa, submucosa. They are some special structures. Because of constipation, these things get dilated and they start getting pulled down. So these dilated anal cushions, which contain hemorrhoidal veins, are nothing but your hemorrhoids. जो आपको यहाँ दिख रहे हैं. So they are nothing but dilated hemorrhoidal veins, and they keep getting pulled down. Now the thing is, they are painless because they are above the dentate line. You can see they are starting above the dentate line. Dentate line के ऊपर की area is painless. So because they start above the dentate line, they are painless, and typically the person will present with painless bleeding during defecation. So he will say, when I sit in the toilet while passing motion or little while after passing motion, few drops of blood fall. So when he's passing motion, I will not use the dangerous word that I used in class once, and you guys harrowed me for it. When he passes motion, if the hemorrhoid tears a little bit, it will start, boon karke, it will start falling. That is called as splash in the pan. I am just going to ignore what you guys, Anmol has written. I am just ignoring it. It is called as splash in the pan. And it will be painless. Normally it will be painless. It will become painful only when it is complicated. So if the hemorrhoid is painful, that means it is complicated or thrombosed. Right? Complicated or thrombosed. Now you need to know diagnosis is simple. If they are seen on proctoscopy, they are normally seen at 3 locations. So when I do proctoscopy, the hemorrhoids are typically seen at 3 o'clock, 7 o'clock, 11 o'clock, 3, 7, 11. Yeah, it is same as piles. Same to same. Pile. Bawasir. Hindi mein bawasir, English mein piles. Medical language, hemorrhoids. So they are seen at these 3 locations. How are you going to treat them? The treatment depends on the grade. Okay. So depending on the grade of the hemorrhoid is the treatment. If it is grade 1 hemorrhoid, grade 1 means don't come out of the anus. They don't come out of anal verge. That is grade 1 hemorrhoid. And it is asymptomatic. You will just do observation. Nothing has to be done. Grade 1 hemorrhoids, observation. If it is grade 2 hemorrhoids, grade 2 means they come out of the anal verge but go back by themselves automatically. You don't have to do anything, they go back by themselves. In these patients, you will do some procedures like banding or sclerotherapy. Did we do banding or sclerotherapy anywhere else in our life? In some other disorder where veins were involved, where also we did banding and sclerotherapy? Yeah, varices. Hemorrhoids are like varices only. There it was in the esophagus, here it is in the anal canal. Okay, but there it was because of portal hypertension, here it is because of constipation. So reason already. So for grade 1, grade 2, this is all you need to do. If it is grade 3 means they come out, but you have to manually put it back inside. So, but reduced manually. This is grade 3. And there is grade 4. Grade 4 means they come out, but they can't be put back. They don't go back, whatever you do. In these cases, you have to do surgery. All right. These cases have to be managed surgically. There are two surgeries you can do. One is this. Other is open surgery. What is the first thing? ये क्या है? क्या कर रहे हैं हम इसमें? पहली चीज क्या है? What is this instrument? And what am I doing here? What is this instrument? This thing, nice looking thing. It's not a proctoscope. Proctoscope से बहुत बड़ा है ये. This is a stapler. Which type of stapler is this? Circular. Excellent, excellent. Very good. So one of the treatments that you see here is with the help of a stapler. This is a circular stapler. This treatment is called stapled hemorrhoidopexy. Stapled hemorrhoidopexy. Okay, it is pexy. It is not ectomy. And the other surgery, if you don't want to use stapler, you can do open surgery. That is called open hemorrhoidectomy. Right, that is open hemorrhoidectomy. Name of the person is Milligan Morgan. Milligan Morgan, open hemorrhoidectomy. So grades of hemorrhoids, they don't come out. That is grade 1. If they come out, but they go back in spontaneously, grade 2. For grade 1, grade 2, banding sclerotherapy is enough. Grade 3 comes out, you have to, he says, I have to push it back in on my own. It does not go back. मेरे को उसको manually ऊपर push करना पड़ता है. That is grade 3. Grade 4 comes out, doesn't go back in. Manually meaning. That is grade 4. Grade 3, grade 4, surgery. Grade 1, grade 2, either do nothing or do sclerotherapy banding. Right? That is about hemorrhoids. The one topic that I hadn't covered. Now you can add it to your notes, right? This we did in class few days back only. If it is a degloving injury, means it is stripped. What is getting stripped? Skin and subcutaneous fat. And what is visible? That is going to be tendon, muscle, deep fascia. All this is going to be visible. Right? Yeah. So what is exposed is deep fascia. Right? Yes, सब आपको दिखेगा. This is degloving injury. These are the kind of questions that come in the exam. Okay. Again, very nice question. Chronic smoker gets cramping pain after walking about 500 meters and the pain is in his calf. Right? Pain is in his calf and it is cramping. If it is cramping, it means it is ischemic pain. So it is not osteoarthritis, it is not insufficiency. If the pain is in the calf, block will be just before it. So block will be femoral artery or popliteal artery. So superficial femoral artery block is the answer. What do I get if it is aortoiliac block? इसमें क्या मिलती है? Block is aortoiliac. Then what happens? तो कहाँ पे होगी उसको पेन? Saphenopopliteal insufficiency is varicose veins. उसमें आपको cramp नहीं होगा. There is no cramping pain on walking. Yeah, aortoiliac block will give me bilateral gluteal claudication. Anything else you get apart from bilateral gluteal pain? ये छोड़ के और भी कुछ मिलता है साथ में? Excellent. Impotence. जो तरीके से आप लोग आंसर कर रहे हो ना, I am very sure you will do well in the surgery part. I am very sure. So this is what you should know. Aortoiliac block, gluteal claudication, impotence. This has a name. This is called Nericious syndrome. Okay, infertility नहीं होती normally, सिर्फ impotence होती है. Impotence may be a cause of infertility, but to call it impotence. This is a new question, but I hope you got this right. That a elderly male who is a smoker, 10 बार मैंने बोला है, painless bleeding in stools, PR is normal. What is the likely etiology? It is going to be C. rectum. Right? It is going to be C. rectum. Why it is not intussusception? Why it is not intussusception? Just out of curiosity. उसमें भी तो होती है ब्लीडिंग इन स्टूल, नहीं होती है भाई, रेड करेंट जेली स्टूल्स होते हैं ना, वो ब्लड के जैसे ही होता. Intussusception is seen in children. Okay, it is seen in children. Normally 6 months to 1 year. Weaning period. Ulcerative colitis, smoking is protective. And it is normally seen in youngsters. Smoking protects you from ulcerative colitis. I am not telling you to start smoking. Huh? Please don't do that. It is protective. And ulcerative colitis is normally seen in teenagers. आपकी उम्र में होगा. Teenagers or people in their 20s. So you are at risk of ulcerative colitis. Meckel's bleeding किन में होती है? Meckel's is also painless PR bleed. Teenager ही हो यार आप, ज़्यादा इतने बड़े नहीं हो. Meckel's is also seen in children. Okay, it is also seen in painless, sometimes painful, but it is seen in children. Okay, 5-6 साल की, आप भी नहीं, आपसे भी छोटा, आपके बच्चे में होगा, आप में नहीं होगा. If you have a child, that's all right. So this is a dictum. This dictum will really help you in your life. Trust me. Okay, this is a PYQ. This has come before. Elderly smoker male. इतने बार मैंने elderly smoker male बोला. I hope you are now rest assured that these questions are made by me only. I hope you got my words when you are solving these papers. आपके कान गूंजने चाहिए ये सब questions solve करके कि हाँ ये सर ने क्लास में बोला था, right? So elderly smoker male with intermittent claudication in his right calf with the site of block. Where do you think is the site of block? And what is the first investigation? Of course, will be arterial Doppler. Claudication in right calf. Where is the site of block? Do you think? Site of block? Yeah, femoral. Either femoral or popliteal. Femoral or popliteal. See, you are becoming legitimate doctors now. Huh? Case for venous Doppler, varicose veins or DVT. Venous Doppler is done when you are suspecting varicose veins or when you are suspecting DVT. उसमें गए. CT angiogram, digital subtraction angiogram are done later. Okay, later you can do it. Venous Doppler is not going to be done in intermittent claudication. Intermittent claudication means ischemic pain. So you are going to do arterial Doppler, not venous Doppler. Okay. Again, this is an integrated question. It is a mix of radiology, surgery, सब मिला के आएगा. Structures identified in a Mickey Mouse sign on venous Doppler include all except. So Mickey Mouse sign is going to show, it will help me locate the saphenofemoral junction, SFJ location. Right. So SFJ location, I need to see great saphenous vein entering into femoral vein. Next to it is its brother, femoral artery, not saphenous nerve. Okay. Saphenous nerve does lie close to great saphenous vein, but it is not seen in Mickey Mouse. So this is Mickey Mouse. Great saphenous vein, LSV is great saphenous vein, long saphenous vein. This is femoral vein. Next to it is femoral artery. That is your Mickey Mouse. So SFJ, saphenofemoral junction. Where is it located? Saphenofemoral junction. What is the location? कहाँ पर होती है बॉडी में? Any idea? Like if I want to anatomically find out its location, where it is located approximately. ग्रोइन तो बहुत बड़ी जगह है, ग्रोइन में बहुत चीजें हैं, ग्रोइन में आपके सारे इंपॉर्टेंट चीजें हैं, उसमें कहाँ कहाँ उंगली लगाओगे, कहाँ कहाँ उंगली करोगे? Popliteal, no, not near calf. Hello, it's not near calf. Excuse me, it's not there. It's like this. See, this is your anterior superior iliac spine. This is your pubic symphysis. Next to it, there is pubic tubercle over here. Okay, and here is your thighs. There is a structure which goes from the pubic tubercle to ASIS somewhere here. ऐसे होती है ना एक structure. What is this black thing that I have drawn? This is the inguinal ligament. ये जो मैंने black में draw किया ना, that is inguinal ligament. Below the inguinal ligament is my thigh. Everything below, everything above is abdomen. Inguinal ligament is the boundary. You can feel it. That skin crease that you see, na, that is your inguinal ligament. This is the pubic tubercle. Okay, this is the pubic tubercle. And you have to go 4 centimeters inferolateral. 4 centimeters below and lateral, approximately, to the pubic tubercle. That is where, over here somewhere, is going to be the saphenofemoral junction, approximately. In you and me, that is where it will be. So don't say groin, don't say thigh. 4 centimeters inferior lateral to pubic tubercle, right? This we had discussed in class, so this should be easy. It was a little tricky question, but patient who has been on treatment for varicose veins, he has a history of ulcer. Okay, which is now healed. So there is a healed ulcer. So healed ulcer, of course, is going to be C5. What is C4A, C4B? They are all skin changes. Like C4A is eczema. C4B is lipodermasclerosis. Atrophy Blanchi, B4 Blanchi, C4B. C5 is healed ulcer, and C6 is active ulcer. Right? So it's all over here. You can see it over here. इसमें लिखा है मैंने. 4B, lipodermasclerosis, atrophy Blanchi. C4C, corona phlebitis. Right? So that is about CAP. We have discussed this in our class, so I hope you got it. What is this? C for corona. Yeah. This is again venous ulcer. Why it is venous ulcer? Because it is located in this typical area, gator area. Okay, because it is located typically in gator area. And you can see around the ulcer, there is eczema. The white patches that you see, shining white area, all this that you see, the white, that is eczema. So eczema is all going to be venous ulcer. Which of these burn screen causes staining of clothes? That is going to be silver nitrate, because the nitrate will stain everything black. Sab kala pad jayega. So if I apply this cream and patient wears any white clothes, they will all become patches of black. Even the furniture, the bed sheets, the mattress, everything will become kala. It gets stained as it gets oxidized. Important about silver sulfur diazine, it shows anti-pseudomonas effect. What is important about mafenide acetate? Usme kya achhi baat hai? What is so good about it? Yeah, mafenide acetate will cause metabolic acidosis. What is the cerium nitrate? I didn't teach this. Cerium nitrate. Cerium nitrate se kya milta hai? What is unique about cerium nitrate? It will give you some benefit. Unique benefit. Anybody knows? It's a burn cream only. It improves local immunity. So when I apply it, it will improve the local cell-mediated immunity. So it is preferred in elderly people who are not having good immunity. It is good for them. Instead of applying silver sulfur diazine, you may apply this. But of course, this is expensive and not easily available. सबसे easily available is silver sulfur. That is what we have used normally in our emergency wards. Okay. Young patient suffered from blunt trauma. He is unstable, right? Blood pressure is low. ऐसे you should solve the question. Important things you should just highlight if you have that option. I don't think computer based test में उतनी option होती है, पर focus on the keywords. Resuscitation is done. Fast is positive. So unstable patient, fast is positive. You are going to do laparotomy. Right? You are going to do laparotomy. Simple. CCT only if the patient is stable. It's not done in an unstable patient. And repeat fast का कुछ sense नहीं बनता. I hope you got this also right. This is a very nice question. These kind of questions come a lot in the exam. 58-year-old male came with perineal pain. Diagnosis of fistula in ano was made. What is the most common type? We have discussed fistula in ano very well. Abscess and fistula. So abscesses were true perineal, ischioanal fossa, suprasphincteric, and submucosal. Anonic fistulae. So same way over here. Most common is type 1, intersphincteric. Second most common is transsphincteric. Right? Suprasphincteric, extrasphincteric, little less. Thode come. They are very rare. This is parts classification. What is the investigation of choice? What will you do next in this patient? Next क्या करोगे? After you diagnose fistula, excellent, MRI. Very good. You will do MRI. Very good. Okay. And what rule used to be applied for patients when MRI was not available? There is a question on this also in the paper. वो मैंने purposely डाला. Purposely I put that question. I don't know if you got it right or not. Let's see. We will see it. पता चल जाएगा. वो मैंने जबरदस्ती उस पे क्वेश्चन डाला. कैसे कैसे क्वेश्चन आएंगे. 40-year-old male, good well नहीं है, good well नहीं, goods all. There is a question on that. 40-year-old female with history of dysphagia. So see, I have not told you whether it is dysphagia to liquid solids. Purposely, I didn't put it. Investigated as shown. Which of these tests is diagnostic? Okay, I asked diagnostic. It is going to be manometry. Why manometry? Because what you see here is, don't say bird beak. It is a smooth tapering. Slowly it is narrowing. Please don't say beak of bird. It is smoothly narrowing. So you think it is achalasia. If the question was next step, then what would you have done? Then the answer would have been endoscopy. Obviously not biopsy. Biopsy नहीं करते, पर endoscopy करते. ठीक है? So next step or first investigation would have been endoscopy. Again, new question. I made this yesterday only. Male presents with flank pain, mild hematuria. The first thing we do whenever there is hematuria is urine analysis, urine routine, urine microscopy, and it shows dumbbell-shaped crystals. What is the investigation of choice? Yeah, you gave that bad mnemonic. Mr. Shubh Patil, they gave a very nasty mnemonic to remember dumbbell-shaped crystals. Very bad one. Mona is dumb. How they come with all these things. Very bad. So anyways, that was not what is asked. What I asked here was investigation of choice. It is going to be plain CT KUB. If they had asked you next step, then what's the answer? If they wouldn't ask investigation of choice, don't blame it on Preeti ma'am. You are propagating it. Okay, she's saying with good intention. You are promoting wrong things. Next step, क्या answer? Next step would have been USG KUB. Okay, or X-ray KUB. Either of them can be done. X-ray KUB or USG KUB. It doesn't matter. Either of them are okay. Yeah. Again, important. If they don't want to ask you how to calculate GCS, they will ask you something little twisted like this. Match the following. What is incorrect? Tongue twister. Tongue twister नहीं है यार. मतलब it's a googly बोल मुरली. It's a googly. Mnemonic. One confused word sounds nowhere. Ashish Khandekar. काय बोलते? You will confuse everyone with that mnemonic. Mind twister. Incorrectly matched. ये matched होना चाहिए. In GCS, eye opening on painful stimulus is E2. Withdraws to pain. This one's a tricky one. Withdraws to pain is going to be M4. And decerebrate posturing, also known as abnormal extension, that is decerebrate. Decorticate is abnormal flexion. Decerebrate is abnormal extension, that is M2. Confused speech is V4. Right? Khandekar का आप mnemonic वापर सकते हो if you want, if you trust that, or you can do it the legit way, like how we discussed it. When I ask you a question, you use, then Siddharth will say, "Yes, I am fine. My name is Siddharth Chaudhary. V5." Then he's confused. Then he'll start abusing me. So V5, V4, V3 goes like that. If you want to use Siddharth Chaudhary, otherwise you can use whatever you want. You can use Khandekar's mnemonic. Identify the organism responsible for this image. So basically, what I have done is a lot of the questions which were PYQs, I transferred them into PYTs. एक step आगे, एक step पीछे कर दिया. So because they may not ask the same repeat. So at least if they're twisted, you should know. So this is a floating membrane sign or water lily sign. This is hydrated cyst formed by echinococcus, right? Entamoeba histolytica will give you amoebic liver abscess. So that will give you amoebic liver abscess. E. coli Klebsiella will give you pyogenic liver abscess. Right? Okay. हाँ, ये आपको पसंद आना चाहिए because hematemesis is something. Plain CT, CCT का एक बार बता दीजिए. Plain CT में you don't put contrast. If there is any CT image later, I will tell you. CCT is when you put contrast. As a rule, whenever you want to look for hemorrhage, you will do plain CT. Whenever you want to look for any pathology where blood vessels are involved, tumors, you will do CECT. Obstruction, you will do CECT because I want to know is there ischemia. So I'll do CECT. So patient presents with massive hematemesis. Diagnosis of varices is made. What is your next immediate step? If I have done endoscopy, okay, if I have done endoscopy, obviously I will do banding, na? If banding fails, or I don't have endoscopy है ही नहीं, or patient is unstable, then I'll do balloon tamponade. यहाँ पर क्यों आपको बलून करना है? अगर आपको एंडोस्कोपी पे वराइसिस दिख गए तो पहले वो ट्राई तो करो. द पाथवे इज गोइंग टू बी वराइशियल ब्लीड, balloon tamponade, टिप्स एंड TAGED, devascularization. ऐसे ही किया हमने, ऐसे ही करना है. So you start with medical management, give him terlipressin, schedule him for endoscopy, endoscopic management. Try it 2 times. Endoscopic management fails 2 times, you go for next step. That is going to be balloon tamponade. If tamponade doesn't work, then tips. If you have it, if tips you don't have, then go for surgical devascularization. Fukugawa procedure. Someone had asked me. Fukugawa. What is this? Beta blocker for long term, absolutely right. Beta blocker is long term management for chronic prophylaxis. Which of these is the most common cause of portal hypertension? So most common is of course going to be cirrhosis of liver. That is going to be intrahepatic cause of portal hypertension. If the question was most common cause of portal hypertension in child or in children, in children, what is the answer? In children, C. Budd-Chiari syndrome. ये आप फेंकते हो. In children, it is portal vein thrombosis. Okay, that is the answer. ये शायद आपको पीडियाट्रिक्स में पढ़ाएंगे, सर्जरी बुक्स में नहीं है ये. मे बी इन पीडियाट्रिक्स इफ आनंद सर टीचेस यू portal vein thrombosis. It is also called as EHPVO. That is the other name for this disease. EHPVO. Extrahepatic portal vein obstruction. This question was also there on my Telegram, same question, but important topic. Elderly smoker male presents with retrosternal burning. Endoscopy shows salmon colored tongue like projections. You know what this is? So, biopsy shows mucus secreting goblet cells, only metaplasia, which means this is Barrett's esophagus without dysplasia. Non-dysplastic Barrett's. Non-dysplastic Barrett's is going to be 0.4. What is the exact value that I have given? What have I taught in class for non-dysplastic Barrett's? Very good. 0.2 to 0.5%. Okay. This value is given in Bailey, 0.2 to 0.5%. Bailey का answer ये है. And 0.7% is for low grade dysplasia. 7% is for high grade dysplasia. Right? On raising the hands above the head, this is seen. What is this? The person is having. Yeah, excellent, excellent. This is called Pemberton sign. So on raising the hands above the head, his face is becoming congested. That is because the retrosternal goiter is compressing the SVC in the thoracic inlet. So this is going to be retrosternal goiter. Very good. Nice question. Central line was being put in the subclavian vein. Patient collapsed when the line was being put. Breath sounds were absent. Hyperresonance was noted. Most likely cause is going to be pneumothorax. Okay, why? Because of hyperresonance. Pneumothorax is the most common technical complication of TPN or neckline insertion. It is the most common technical complication. What is the most common overall complication of TPN? Most common overall complication of TPN. ये हमने TPN वाले टॉपिक में कवर किया. Neurogenic shock नहीं होगा. It won't lead to neurogenic shock. It can lead to vasovagal syncope sometimes. It is catheter sepsis. Okay, that is the most common complication. Catheter line sepsis. Overall most common. Okay. Child is born with this neck swelling. The swelling is brilliantly transilluminant. This is likely to be due to a defect in. So this is cystic hygroma. Wonderful. This is cystic hygroma, which is normally seen in the posterior triangle, where you see over here, posterior triangle. And it is due to a lymphatic malformation, right? Lymphatic malformation. Sublingual salivary gland में कौन सी बीमारी होती है? What occurs in sublingual salivary glands? Ranula. Very good. So cystic hygroma, sequestration of lymphatics. This image that you are seeing, this swelling here, in the floor of the mouth, that is ranula. It is going to occur in the floor of the mouth. Cystic hygroma in the neck, posterior triangle, ranula, floor of the mouth. Treatment for both is excision. दोनों का इलाज सेम ही है. They are like cysts. Treatment is going to be excision. Okay. शुभ ranula में एक ही L है, रसगुल्ला नहीं है, ranula है. There is only one L in ranula. Okay. Female has undergone total thyroidectomy. This is the PYT. मैंने options change कर दिए. PYT है previous year topic. Histopath shows papillary thyroid cancer. What would be the further management of this patient? PDF will come on the app. App पे मिलेगा, मेरे से नहीं मांगना. ठीक है, app पे मिल जाएगा आपको. So answer is going to be serum thyroglobulin and USG neg. This you will do every 6 months to 1 year. What answer did we discuss in class? PYQ क्या था इसमें? What is the answer given in the PYQ? ये option नहीं था. Yeah. Apart from this, you are going to do whole body iodine scan. Actually, this is what you do. Whole body iodine scan. Why are you doing it? To look for metastasis. But I will say it again. This is only going to be done if patient had a papillary thyroid cancer, follicular thyroid cancer. What is the use of option A? This will tell me about recurrence. So after removing the tumor, thyroglobulin should become 0. If after 6 months, 1 year, 2 years, thyroglobulin starts increasing, in that case, I will get an idea. Maybe he's having recurrence. Tumor is coming back. It can come back anywhere. It can come back in the neck, or there can be metastasis. So it will tell me about metastasis. This was a play upon words kind of a question. थोड़ा आपको गुमराह करने के लिए था ये question. That A, B, C, D of trauma. What does D stand for? And I guess all options seemed similar. D stands for disability. And basically disability means GCS and pupils. The answer is going to be assessment of neurological status. When do I check this? Fractures. Assessment of fracture कब होते हैं? हो भी गए गुमराह? अरे रे गुमराह क्यों हो गए? Assessment of open fracture is done in exposure. Detailed head-to-toe examination is secondary survey. Identification of death is done in forensic medicine. ठीक है? Anathology वहां पर करना आप ये. मेरा भी गलत हो गया. क्यों गलत कर दिया आपने? A is airway with cervical spine immobilization. Airway plus C spine. B is breathing. C is circulation. D is disability. E is exposure. ठीक है? This is your ABCDE of trauma. Okay. Type 2 diabetic, elderly. He comes with this funny looking thing. What is he having? Disability के चक्कर में आप फंस गए, पता है मुझे. What he's having here, this is Fournier gangrene. Also called as necrotizing fasciitis. Also called as synergistic gangrene. And what are you going to do here? You're going to do a radical surgical debridement. Orchidectomy is not done because testes are spared. SPC कब कौन से बीमारी में हम SPC करते हैं? Normally when do you do SPC? नहीं नित्या ऐसे मत कर, गलत जवाब मत दे. SPC is done in urethral rupture. Bladder नहीं रे, urethral. It is done in urethral rupture. Because in urethral rupture you will see blood at meatus. If you see blood at meatus, then you will not put catheter, let the bladder distend, and you will do SPC. Okay, this is a PYQ. This I think we discussed in class also. 2-3 साल पहले आया है ये. Patient underwent cholecystectomy. Now he comes with upper abdominal pain, which means he has acute bile duct injury. MRCP showed leak from cystic duct stump. What type of injury is this? This is type A. Type A. This is type A. Bile duct injury. He is stable. Next line of management will be ERC. If it was type B, type C, type D, then what would you do? MRCP showed type B, type C, type D, any of them. Then what would you do? You would do a delayed reconstruction. All right. You would do a delayed reconstruction after 2-3 months. Right. So first you put first you do ultrasound, then you put pigtail or you drain. So sepsis control. Then you do nutrition. Then you do MRCP, and then you decide how you want to treat it after MRCP. What is this instrument? What it is used for? Name of the instrument, use of the instrument. Very good. This is Humvee knife. उस दिन ही करा था हमने. This is used for harvesting a split thickness skin graft. How much is split thickness? Split thickness माने कितनी thickness? How much should be the thickness in split thickness? It should be epidermis plus upper or partial dermis. Okay. Epidermis plus some amount of dermis, not full dermis. If you take full dermis, it is a full thickness skin. What is this device? Very nice looking. ये कौन सी डिवाइस है? पिलर। ये क्या है? पिलर क्या होता है? माइक्रोटोम। दिस इज कॉल्ड डर्माटोम. इट इज यूज टू हार्वेस्ट द स्पिट थिकनेस का. दिस इज डर्माटोम. लेजर नहीं है ये, डर्माटोम. ये क्या है? ये तो देख के बता सकते हो. चपटा करता है. चपटा वपटा नहीं कर रहा हो कुछ भी. या दिस इज अ मेशर. ठंडे करने का. आज आप लोग का मूड बहुत अच्छा है, पता नहीं क्यों. आज आप लोग पूरे मस्ती के मूड में. नेक्स्ट टाइम आई विल पुट सच अ डिफिकल्ट क्वेश्चन पेपर ना. आप लोग मेरी क्लास में आना बंद कर दोगे. ऐसे करना पड़ेगा मुझे. Because Janvi ma'am iPad. How do you know that? I didn't say Janvi ma'am iPad. I just said I'm using some other laptop. 10-year-old boy presents to OPD. His left scrotal sac is empty and underdeveloped. On clinical examination, his left testis in the left superficial inguinal pouch. I said I am not using my laptop. I didn't say iPad. iPad कहाँ बोला मैंने? iPad तो मेरी हो सकती है ना? Yeah. What is the diagnosis in this case? This is ectopic testis. But I had not asked next step in class. Class में मैंने ये नहीं पूछा था. This is ectopic testis. What is the next step for ectopic testis? Why left? I don't want to do bilateral exploration. So I want to bring it down. तो एक साइड में, दूसरे साइड का क्या? कोई ऐसी बीमारी है क्या where you do bilateral exploration? मैंने ये ऑप्शन क्यों डाला? Bilateral scrotal exploration. Yeah, this is done in torsion. Okay. Don't mix up the two. In undescended testes, you will only explore the side where the problem is. In torsion, you will explore both testes. Okay. In torsion, you will explore both testes. That was a trick that I put over here. Right. So, undescended testes, normal pathway of descent. Ectopic testes, abnormal pathway of descent. And ectopic most common site is superficial inguinal pouch. And here it is high scroll. Okay, they are the commonest sites. Okay, जो बचा है उसको सेव करने के लिए both side explore. Correct. 50-year-old male presents after undergoing total thyroidectomy. He has perioral tingling, perioral numbness. Patient has no history of any trauma. What test should be done? What is this diagnosis? So person is having post-operative hypoparathyroidism. Okay, post-operative hypoparathyroidism. This normally happens because of ischemia. Because inferior thyroid artery is what supplies parathyroids also and lower part of thyroid also. So you are going to check PTH levels, calcium phosphate. One question I want to ask you: during surgery, if I accidentally remove the parathyroid, then what should I do? If during surgery I accidentally remove parathyroid, then what should I do? Put back where? Put it back where? Place it back where? Biceps. So remember, if it is accidentally removed parathyroids, you will replace it back into sternocleidomastoid muscle. Okay, means in the neck. वो जो हम forearm में डालते हैं ना, that is not here. Forearm implantation is done for parathyroid hyperplasia. So if I have parathyroid tumors in all the 4 parathyroids, which is seen in MEN 1, MEN 2 syndromes, if all 4 parathyroids have tumors, then I remove all 4 intentionally. One of them, small pieces, I put back over here, not in the neck. Okay. So forearm implantation is for parathyroid hyperplasia. Please be very clear about this. इस पे मैंने एक रील भी डाली है मेरे इंस्टाग्राम पे. Forearm implantation is for parathyroid hyperplasia, where the parathyroids are diseased. Diseased parathyroids you replace in the forearm, not in the neck. Normal parathyroid जो गलती से निकाल दिए, back in the neck. Neck में छोड़ दो वापस. right? Patient comes with ulcers, burning sensation. He has this lesion. What is this lesion and what is the next step? This is leukoplakia, LP. Next step is going to be biopsy. If biopsy shows dysplasia, then what will you do? If I see dysplasia, that question gets answered, then you will remove it. If biopsy shows no dysplasia, then what will you do? Why not excision? Iska answer aayega. If there is no dysplasia, then what will you do? Leave it, no. Tell him to stop smoking, stop alcohol, and just do surveillance. Because leukoplakia is not very high risk. More high risk erythroplakia, spectral leukoplakia, those you will always excise. Leukoplakia can be observed if there is no dysplasia. So you take away the risk factor, you may be able to get away with excision. You may be able to get away without excision. It's possible. So malignancy risk in leukoplakia is relatively less compared to the other ones, compared to erythroplakia. Okay, patient presents to the clinic with complaints of lower backache. It is found that he has prostate cancer. So I told you, prostate cancer ऐसे diagnose होगा, lower backache and all. And the cancer is spread to the lumbar vertebra. How has it spread to lumbar vertebra? Via the prostatic venous plexus. It is a hematogenous spread. So CA prostate hematogenous. Very good, Mr. Azhar. Excellent answer. It is via the Bateson's plexus. Okay, Bateson's venous plexus. उससे होता है. So obviously CA prostate will go to lumbar vertebra because they are close to each other via the prostatic venous plexus. Triage हमने किया नहीं था. Yeah, breast cancer also same. A lot of urological cancers will go via the Bateson's plexus only. Patient is classified as green according to the triad system. This is going to be ambulatory patients. For ambulatory patients, green. Medium risk patients, and high risk patients, and dead patients. Green, yellow, red, black. Give me example of each. So ambulatory patient, someone with a simple fracture or someone with a simple wound is going to be green. Yellow, remember, degloving injury is going to be yellow. Means urgent, not immediate, but urgent. So degloving injury, open fracture is going to be yellow. Red, EDH, tension pneumothorax, airway obstruction. Black is going to be more than 70-80% burns or any trauma after which the person is unlikely to survive. He is about to die, moribund, almost dead. Yeah. Okay, 6-week-old infant, history of projectile vomiting. There is a mass in the epigastrium. What is the diagnostic test? What is the child having? Very good. Why IHPS? Kaigo, what told you it is IHPS in the history? How did you come to this diagnosis of IHPS? Non-bilious कहाँ लिखा है इसमें? मैंने तो नहीं लिखा non-bilious. What I want you to say is, sir, because the child is 6 weeks old. 6 weeks old child means anything between 4 to 8 weeks. That is when you will get IHPS. Of course, projectile vomiting I have not given, but it will be non-bilious. And this mass that you will feel, when is the mass felt? We had to change this in our notes. When is the mass felt? No, when do you feel it? When should you feel it? After feeding, better than after feeding. Unfed feeding is not important. He should be a relaxed child. He should not be crying. He should be relaxed. Okay. In the notes, it is given unfed. Please change that. Okay. Unfed is not important. Feeding, not feeding. That's not important. What's more important is he should be relaxed. He should not be vomiting. He should not be crying. And USG abdomen is going to be the test of choice. The treatment is going to be Ramstad's pyloromyotomy. Okay, it's going to be Ramstad's pyloromyotomy. This also is a topic which we will discuss a little bit. We didn't do it in class before. So 8-year-old boy presents with history of bleeding PR. Colonoscopy was done, but the site could not be identified. What is this image? The image क्या है? I don't know if the image helped you or not. What is this image? Excellent, excellent. No, no, it's not PET scan. It's not iodine uptake. अरे iodine uptake यहाँ कैसे होगा? अगर आप लोग थोड़ा गौर करोगे ना, little bit, थोड़ा दिमाग लगाना है इसमें. Something is written over here. पे लिखा हुआ है ना, TECH. TECH क्या है? Technetium, yeah, it's technetium scan. So this is technetium 99 scan. In this case, it is used to identify ectopic site of gastric mucosa. Over here, it is to identify ectopic gastric mucosa. So what you see here, this is normal stomach, normal gastric mucosa. But you see here gastric mucosa. Why is there gastric mucosa here? Because here there is a Meckel's diverticulum. Okay, so Meckel's diverticulum may have ectopic gastric mucosa, and Meckel's diverticulum normally happens in the ileum, 2 feet proximal to IC junction. So it is in the ileum. So it's an ileal diverticulum. है ना? like सब कुछ abnormal, कुछ तो normal भी होगा ना, कुछ तो normal भी होगा. Anyways, if you couldn't identify this, नहीं समझ में आया. 8-year-old boy cannot be intussusception because intussusception is seen in weaning period. Polyposis हो सकता है, चलेगा, पर colonoscopy should be diagnostic. So colonoscopy would have identified Crohn's disease. There is no bleeding. There is no bleeding. And Crohn's disease again is seen in teenagers like you. It is seen in teenagers. उम्र देख के आप रूल आउट कर सकते थे. बिकॉज अरे पॉलिपोसिस है तो क्यों नहीं दिखे कोलोनोस्कोपी में? पॉलिप तो दिखने चाहिए था ना, नहीं दिखे. So answer is going to be Meckel's diverticulum. Okay. So remember, Meckel's diverticulum, the rule of 2 is okay. It is seen in 2% population. It is seen 2 feet proximal to IC. And those are not the important rules. The important rule is that it contains 2 types of mucosa. One is gastric, other is pancreatic. MCQ में ये पूछते हैं. If it contains gastric mucosa, it will present with PR bleed in a child. So the presentation in a child is going to be PR bleed. Because this gastric mucosa will produce gastric acid. Because of gastric acid, the child will get ulcers. कहाँ पे? Ileum में. Ulcers in ileum. So the child will get bleeding. In an adult means there is no gastric mucosa. He may present with inflammation. Like appendicitis. He will have diverticulitis. So to diagnose in a child, you will do this technetium scan. In an adult, how will you diagnose diverticulitis in an adult? एडल्ट में ये स्कैन मत करना, स्कैन का फायदा नहीं होगा क्योंकि उसमें गैस्ट्रिक म्यूकोसा नहीं है. म्यूकोसा सिर्फ बच्चों में होती है. यू विल डू CC. वेरी गुड. पहले जमाने में यू वुड डू बेरियम मील. इट वाज कॉल्ड बेरियम मील फॉलो थ्रू. पहले करते थे, आजकल आप CT करोगे. एंड द ट्रीटमेंट, अगेन देयर आर 2 टाइप्स ऑफ ट्रीटमेंट्स. इफ इट इज अनकॉम्प्लिकेटेड, फाउंड ड्यूरिंग सर्जरी, incidental, then you will do nothing. Leave it. And if it is complicated, causing any problem, you will do excision. Right? So if the person presented with Meckel's diverticulitis, you will do excision. Okay? That is also called as diverticulitis. Two important terms. POEM is done for easy achalasia. Which type of achalasia will you prefer POEM? It is preferred for which? It is preferred for type 3 achalasia, which is also called as spastic achalasia. In type 1 and type 2 achalasia, you will do this procedure, Heller's myotomy. So Heller's procedure preferred in type 1 and type 2. And what is the extent of myotomy? VIMP. Extent of myotomy in the lower esophagus, about 6 centimeters. And in the cardia of the stomach, about 2 to 2.5 centimeters. ठीक है, ये नंबर पता होने चाहिए, काम के नंबर अपने ये अगेन वेरी नाइस क्वेश्चन, VIMP question. Female with history of migraine, taking NSAIDs. She comes with acute onset abdominal pain, vomiting, X-ray. What do you see in the X-ray? दिखता क्या बड़ा है? So what you see here, this is right dome. This is air under diaphragm. Left dome, air under diaphragm. Why this history? Migraine. Migraine history क्यों दिया है मैंने? इसका कुछ संबंध है? ऐसी टाइम पास के लिए दिया है मैंने. Because NSAIDs will cause peptic ulcer. So what I'm trying to tell you is this is peptic ulcer which has now perforated. So he's come with perforation which is seen on X-ray. So the answer is going to be surgery. If in this case X-ray, if it is normal, then what would you do? What will happen if surgery is delayed? Person will get peritonitis and septicemia and he will die of septicemia. If X-ray normal, then you will do CT. Because CT is the investigation of choice. But again, I'm saying investigation of choice does not mean I have to do it. Compulsory nahi. I may do it if I want. It's not a compulsion to do it. अगर मेरे को मिस हो गया है एक्सरे पे तो ही मैं CT करूंगा, वरना करने की इसी गरज नहीं है. It's not mandatory. This we didn't discuss. For what IOC? IOC for pneumoperitoneum. Investigation of choice for free air is going to be CT. How much air CT can detect? Quantity of air CT can detect, quantity of air X-ray can detect. Since you asked, X-ray will detect if the air should be more than 10 to 20 mm. How much air CT can detect? Sensitivity of CT 100 cc, ज़्यादा 50. So then CT is worse ना, अगर CT is having such poor sensitivity. 10 से 20 से तो कम ही होनी चाहिए ना. It is more than 1 ml. 1 ml air also is going to be detected on CT, even 1 ml. But I don't need it. क्योंकि अगर परफोरेशन हो गया 10, 20, 50 ml तो हवा चली जाती है, तो एक्सरे में दिख जाती है, नहीं दिखेगी तो CT का. Yeah, we didn't discuss this. Advantages of minimal access surgery. For example, why is lap chole better than open cholecystectomy? For example, this is lap chole, lap appendix. Why are they better? What is the answer? Why short learning curve is not the answer? इसमें क्या प्रॉब्लम है? लर्निंग कर्व शॉर्ट है ना, अच्छा है ना शॉर्ट लर्निंग कर्व. Better recovery post surgery. See, whenever I put small cuts, na, when I do laparoscopic surgery, I make very small cuts. If the cuts are small, the pain is less. If the cuts are small, instead of having a big laparotomy, the intestines are not very exposed. Intestines are all inside. They are not exposed to the environment. So heat loss will be less. Paralytic ileus will also be less. And my camera can go wherever I want it to. So I can put a camera and it can go in the pelvis, it can go in the hiatus. So deep cavity surgery is easier, like surgeries in the pelvis. Learning curve is not short. Unfortunately, it's a long learning. Which means to get a mastery, you need to do more surgeries. Like for example, if I want to learn to do open cholecystectomy training, I can learn open cholecystectomy. Even if I do say 10-15 cholecystectomies, 10-15 cholecystectomy मैंने कर लिया ना, I have learned it. But if I want to learn a lap surgery, I will have to do it at least 25 to 50 times. So laparoscopic training requires more practice. That is the main drawback. पर एक बार आप सीख गए ना तो कोई प्रॉब्लम नहीं है, फिर आराम से कर सकते हैं. एक बार ट्रेनिंग चाहिए होती है बस. That is the only thing. Right? So these are the advantages and disadvantages. So we'll do this question, then I'll give you a little break, 5-10 minutes break, then I'll come back. 5-10 minute का ये break दूंगा, ज़्यादा लंबा नहीं दूंगा. And then we'll continue. So we'll just do this question that Hinchi classification is used for. Cautery से heat release होता है इसलिए नहीं, उससे संबंध नहीं है. So Hinchi classification is used for complication of diverticular disease. Which complication is this? कौन सी complication है diverticular disease की? Where you use Hinchi classification? It is for diverticular perforation. Okay, it is for diverticular perforation. That is this. So stage 1, pericolic abscess, stage 2, pelvic abscess, stage 3, purulent, stage 4, fecal. ये fecal na has the maximum mortality. What is the image that you see next? What is this image? क्या image है? Yeah, this is a barium enema. And this appearance that you are seeing, this is called sawtooth. Very good. Okay, this is a sawtooth appearance on barium enema. Okay, important question. 35-year-old man in an inebriated state fell in the bathroom. He had intense pain in the suprapubic region. Abdominal distension was present and no blood was seen at meatus. So if there is no blood seen at meatus, it is not a urethral rupture. So you have ruled out urethral rupture straight away. And he is unable to pass urine and abdomen is distended, which means it is intraperitoneal rupture leading to peritonitis. Right. So the diagnosis is going to be intraperitoneal rupture with peritonitis. That's how you have diagnosed it. Okay. Let's see this one. 56-year-old male recently diagnosed with RCC and the tumor is less than 4 centimeters in size. What would be the most appropriate? Why not partial nephrectomy with chemotherapy? ये क्यों नहीं है? Normally we do that ना, nephrectomy or whatever with chemotherapy. Why no chemotherapy option here? यहाँ पर क्यों नहीं कर रहे हम chemotherapy? No meds, contraindicated. No, because RCC is chemo and radio resistant. Yeah, very good. It is chemo and radio resistant. So obviously, if it is going to be resistant, these options are out. Tumor less than 4 centimeters is going to be T1A, and T1A is going to be partial nephrectomy. If it was T1B, you can do either. T2 onwards, it's going to be radical nephrectomy. Patient presents with herniation of intestinal loops, along with which pass along the spermatic cord and reach the bottom of the scrotum. Means the hernia is accompanying the spermatic cord. It is accompanying the spermatic cord like this and going all the way till the bottom of the scrotum. पूरी नीचे तक जा रही है hernia, and there is a defect from where the hernia is coming is the deep ring. So obviously hernia occurring through deep ring is going to be indirect hernia. What is the defect in a direct hernia called? Direct hernia occurs from what defect? Quickly tell. Direct hernia, what is the defect? Very good. Hasselbalch triangle. So direct hernia, Hasselbalch. Indirect hernia, deep ring. Deep ring is a defect in what? कहाँ से आ रही है deep ring? It is a defect in what? It is a defect in fascia transversalis. Remember I taught you that posterior wall only has fascia transversalis. The other muscles, the internal oblique वगैरह, they don't come inside. So you only have fascia transversalis. Boundaries of Hasselbalch triangle. You want me to tell you revision? I will tell you. So medially, it is going to be rectus abdominis muscle. Laterally, which came in FMG exam, is going to be inferior epigastric artery, and inferiorly is going to be inguinal ligament. ठीक है? So ऐसे you want to remember medial muscle, inferior inguinal. ठीक है? और फिर ये इंफीरियर को इंफीरियर एपिगैस्ट्रिक मत करना, निमोनिक में फिर लफड़ा हो जाएगा. निमोनिक याद करने के लिए भी निमोनिक लगते हैं, वो मत करना. इससे अच्छा है नॉर्मल एनाटॉमी सीखनी चाहिए. 7-year-old girl from Bihar presents with pain in the right upper quadrant with a lump in the abdomen, and she has a conjugated hyperbilirubinemia with a dilated CBD. What is she having? This young girl, young Asian girl with a lump, with pain. स्टोन क्यों होगा? 7 साल की लड़की में स्टोन क्यों होगा? Lump with pain in a young girl, and this conjugated hyperbilirubinemia means she has obstructive jaundice. What is she having? What is the diagnosis? स्टीवन जॉनसन. स्टीवन जॉनसन नहीं है ये. उसमें डायलेटेड सीबीडी क्यों होगी? डायलेटेड सीबीडी. Yeah, she is having choledochal cyst. Thank you. This person is having choledochal cyst. Anyways, even if you didn't know the diagnosis, you know she's having jaundice. First thing you will do will be LFT. Next step will be USG. Next step will be MRCP. So any patient with obstructive jaundice, LFT plus USG. Depending on what you get in this, most of the time, next step will be MRCP. Most of the times, right? HIDA scan is like nuclear imaging. It is not very commonly done nowadays. Yeah. I have put one question on ERCP also later. Person diagnosed with duodenal ulcer, you are planning surgery for duodenal ulcer with surgical options below has the least recurrence. So remember, least recurrence will be combined procedures. HIDA scan is not the next step. Next step is MRCP. Okay. So least recurrence, truncal vagotomy with antrectomy. If they ask you best tolerated, it will be highly selective vagotomy. Okay, highly selected vagotomy. That is going to be best tolerated. I will show you this table. I have shown it in class also that vagotomy with antrectomy, lowest recurrence, highly selective vagotomy, least side effects. है ना? Important है ये. At least maximum minimum तो आना चाहिए. Or common sense. HIDA is for biliary atresia. Absolutely right. But it's not the investigation of choice. For biliary atresia, the gold standard is going to be biopsy. 65-year-old male smoker presents with painless hematuria. He is found to have bladder cancer, limited to mucosa, but invading lamina propria. What is the T stage of this bladder tumor? Limited to breaching lamina propria. What is the T stage? This is pathological T1. Very good. Treatment is going to be intravesical chemotherapy. Right? Intravesical chemotherapy. This is going to be done for muscle invasive. If it is pathological T2, pathological T3, sometimes pathological T4. In this case, you will do radical cystectomy with ileal conduit. For pathological T1, you are going to give contact chemotherapy. As Nikhil had used the same word that time also. Again, a very important question. You are going to get these kind of questions in the exam. FMG exams are becoming more and more clinically oriented. Woman presents with nausea, vomiting, loss of appetite, abdominal pain with history of ileocecal TB. Abdomen is distended. It is tender. There is increased peristalsis. Bina X-ray also you can give diagnosis. So distended with hyperperistalsis means she is having a mechanical block. This means she is having mechanical obstruction. And she has history of tuberculosis. What's the connection between TB and mechanical obstruction? Connection है कुछ दोनों में? Image देख के ही आंसर लगा दिया. अमेजिंग, बिना इमेज के आंसर लगाओ तो मैं मानू। ये शाहरुख, एब्सोल्युटली राइट। दिस मींस शी इज हैविंग अ आइडियल स्ट्रक्चर, एक्सेलेंट। आईसी जंक्शन और टर्मिनल आइडियल स्ट्रक्चर, ऐसा सोचोगे ना यार, आप सर्जरी में सारे क्वेश्चन सही कर दोगे। सो दिस इज गोइंग टू बी अ ऑब्स्ट्रक्शन, मैकेनिकल ऑब्स्ट्रक्शन, एंड व्हाट यू सी इन द इमेज, air fluid levels in a step ladder pattern. So it is going to be step ladder. So it can't be paralytic ileus, it can't be pseudo obstruction. Pneumoperitoneum you don't see in the image. You don't see free gas, so it's not pneumoperitoneum. Okay, this question I had asked in the class. Patient underwent surgery for rectal prolapse. This is the image. I have shown you this image. This is going to be Thiersch's stitch or Thiersch's anal wiring. Okay, this is going to be Thiersch's anal wiring. This Wells procedure is abdominal procedure. It is an abdominal procedure where you use mesh for rectal prolapse. Altemeyer is another perianal procedure where you do a resection. So Altemeyer is a type of resection. Thiersch's is a type of wiring. And which was the third procedure, which was also done perianal, apart from Altemeyer and Thiersch's? What was the third procedure? Delorme. Excellent. That was Delorme procedure. Very good. Easy question. Rutherford Morrison incision is used for what? That is going to be appendectomy. Best answer is open appendectomy. What is the unique thing about this Morrison incision? What is unique about it? Extended, yes, it is extended, and it is a longer incision. It is an extended incision, and it is a muscle cutting incision. Which nerve can get injured when you do muscle cutting in this Rutherford Morrison incision? There is injury to which nerve? It can injure. कौन सी nerve? Excellent. Iliohypogastric. There is a risk of injury to iliohypogastric nerve. This only happens in this Morrison incision. It does not happen in the other incision. The normal incision that you use, which we call as the gridiron, also called as the MacArthur incision. वो incision में it is a muscle splitting incision. No muscle is cut. उसमें nerve injury नहीं होगी. And the incision which is cosmetic, that is your lens, skin crease incision. It is a cosmetic incision. Right? Very good. I don't know if you got this, but it was another very tricky question. Boy presents with right-sided acute scrotum. Examination reveals tenderness which worsens on lifting the testes. What is the boy having, and what is this test called? The boy is having torsion. What is this test? You must have written all of the above, I am sure. Phrenic nahi, Prehen test. It's called Prehen's test. All of these abnormalities are seen, no doubt. But I asked you most common abnormality. So most common is going to be high investment of tunica vaginalis. तीनों भी हो सकते हैं, but सबसे common है ये high investment of tunica vaginalis, also called as bell clapper effect. Torsion ढूंढ रहा था option में. This is called bell clapper effect. जैसे मंदिर का घंटा होता है वैसे उसकी टेस्टीज हो जाती है मंदिर के घंटे की तरह. Okay, all of these are components of Men syndrome. Men 3. What is Men 3? ये कौन सी नई syndrome आ गई? Men 3 syndrome. Yeah, Men 3 is other name for Men 2B. In Men 2B, you get MTC and pheochromocytoma. They are common in both Men 2, whether it is 2A or 2B. ये दोनों में होते हैं. But you get the other ends. Megacolon, Marfanoid, habetus, mucosal neuroma. Parathyroid adenoma is not seen. Okay, so first and foremost, these are common. Medullary thyroid cancer is seen in 90 to 100% of cases of Men 2B. Pheochromocytoma is seen 10 to 60% cases. And these are the other variables. Okay, so Men 2B and Men 3 are the same. Men 2A has the same MTC, pheochromocytoma, They are common. What is the third component in MEN2A? तीसरा क्या होता है इसमें? Third component in MEN2A, parathyroid hyperplasia. Hyperplasia. Okay, parathyroid hyperplasia. Both of these are due to RET gene mutation. Okay, RET gene mutation. This was easy, but this is important. Not a contraindication. I hope you didn't make a mistake in this. Not a contraindication. RET, TEN, MED, MAN. Wow, I don't know what that means, but it sounds very scary. RET, TEN, MED, MAN. Red 10 Medman. सुन के दिस इज ब्रेन ट्विस्टर जो उसने लिखा ना शुभ पटेल ने, वो ब्रेन ट्विस्टर ये है, रेड 10 मैडमैन। अरे भगवान, कुछ तो नॉर्मल तरीके से नहीं सीखना है आपको, फैंसी तरीके से सीखना है। सो नॉट अ कॉन्ट्राइंडिकेशन फॉर बीसीटी इज पैल्पेबल axillary nodes. If palpable axillary nodes are there, you will do straight away axillary clearance. I just told you this today. Straight away you will do axillary clearance. You don't need to do sentinel lymph node biopsy. Microcalcification is a contraindication for the wide local excision. This is a contraindication for radiotherapy. This is again a contraindication for wide local excision. Right? तो ऐसे आप डिवाइड कर लो, इजी हो जाएगा। रेड जीन, क्रोमोसोम 10, मेडुलरी, MEN2A, 2B, एकदम ही भयानक है, भयानक। Wow, I get scared when I listen to all this. This is a PYQ. This has been asked in FMG exam before. Conditions shown in the image below. So there is a stone here which is compressing the common hepatic duct. This is going to be Mirizi's syndrome. What is the investigation of choice for Mirizi's syndrome? What is the treatment for Mirizi's syndrome? Investigation of choice, treatment. ERCP is never going to be the investigation of choice. It is MRCP. Okay, ERCP when I know the diagnosis, and treatment is going to be lap chole or cholecystectomy. But if there is an injury here, that has to be repaired with repair of injury. Like maybe there will be a hole in the common hepatic duct, that has to be repaired. So with repair of fistula, if there is any. ये सवाल अच्छा है. This came in NEET 2021. Patient presents with fever, jaundice, and upper abdominal pain. Patient has a stone in the common bile duct with dilated bile duct and biliary radicals. What is the next appropriate step? What does it mean? It means the person is having CVD stone. Ultrasound is telling me there are CVD stones. I know he has CVD stone. And what is this fever, jaundice, pain? What does this mean? Fever, jaundice, pain? क्या है ये? Yeah, this is Charcot striate, which is seen in Charcot striate, seen in Forcott. Okay, गलत हो गया, C लगाया था, CCT, इसलिए तो मैंने डाला, सारे थोड़ी इजी डालूंगा. No, not cholecystitis. This is seen in cholangitis. Charcot striate is seen in cholangitis, not cholecystitis. Cholecystitis, Murphy sign. Murphy sign cholecystitis. Cholangitis, Charcot striate, you will do ERC. Okay, so investigation of choice for CVD stone, MRCP. If stones are diagnosed, next step, ये change कर दो, next step, ERCP. Please change this up. Investigation of gallstones, USG. Pana, Tipu, Charcot. बढ़िया. Okay. Patient presents with acute abdominal pain after alcohol binge. This image is seen. What is this called? This is Gray Turner sign in acute pancreatitis. Very good. So person is having acute pancreatitis or acute hemorrhagic pancreatitis. That is Gray Turner sign. This we didn't discuss. What is this? Nice looking thing. So what I want you to focus here is this is the umbilical tube and something is wrong infraumbilical. So there is an infraumbilical defect. Okay, infraumbilical defect. Vital intestinal duct will be seen at the umbilicus. This will be an umbilical defect because the vital intestinal duct connects the intestine to the umbilicus. Vitalo means umbilicus. This is infraumbilical. This is going to be extrophy of bladder. Extrophy of bladder means the lower abdominal wall, so the wall below, is missing. So there is a hole over here in the infraumbilical abdominal wall. यहाँ पर. And इसमें से the bladder is jutting out. So the urinary bladder comes out. So what you are seeing here, this part, is probably the urinary bladder. Urinary bladder, it is coming out. That is called as ectopia vesicae. Okay. Cloaca नहीं है. Ectopia vesicae. Extrophy of bladder. It is a congenital defect. So there are three defects: infraumbilical, extrophy of bladder. It has to be repaired. These must be the genitalia. Okay, you can't make out the genitalia, but it must be the genitalia. I don't know whether it is scrotum or whether it is labia. Can't make out. But yeah, it is a genitalia and bladder. Only bladder comes out from this. Gastroschisis, it is the defect in the right umbilicus. It is seen in teenage mothers. And the intestines are bare. And omphalocele is covered by peritoneum. It is an umbilical defect. We have discussed this in our class. Another important question. 55-year-old patient underwent hysterectomy 2 years back. Now presents with colicky abdominal pain, bilious vomiting, which means he is having intestinal obstruction. Exaggerated bowel sounds means it is a mechanical obstruction. Multiple air fluid levels are seen, mechanical obstruction. So many clues are there. So many. What is the diagnosis? Adhesive obstruction. This is the most common cause. So this is the most common cause of intestinal obstruction. In paralytic ileus, there will be no hyperperistaltic sounds. Bowel sound will be absent. And it will not happen after 2 years. Okay, 2 साल बाद नहीं होगा. Did you get this right? 3 patients, we discussed this. We gave 2 examples. One was Siddharth and other was Totipotent. 2 people, Siddharth and Totipotent, we discussed this. So I don't see any of them here, unfortunately. Makes me sad. So their GCS is given. They have the same GCS 999. Do they carry the same prognosis? No. Patient C has the better prognosis because motor response is the most important. Right? Motor response, but only if they have the same GCS. ऐसे मत बोलना कि कोई भी GCS हो motor response. Same GCS में motor response obviously will be better. Totipotent left after mass ragging. उसने नाम ही नहीं बताया. पता कैसे चलेगा कि Totipotent boy भी था या girl थी? वो भी नहीं पता. Child has scarred burns on his hands due to hot water treatment. The lesion is pink, oozing, painful. What is the depth? Pink, painful, second degree superficial. Same motor response, then obviously same prognosis. Now, अगर ये सब कुछ same है, EB, V, M, if all is the same, E3, V3, M3, E3, V3, M3, obviously same prognosis. Alright, so pink, moist, painful are going to be second degree superficial or superficial partial thickness. Here the question seems very difficult. ऐसे questions are made on ChatGPT. ChatGPT question है, लेकिन easy question है. Patient underwent hernia repair, mesh repair. He complains of persistent pain. He is okay. There is no sign of infection. He is taking pain medication, nerve blocks, everything is recommended. He was able to return. Question क्या है? Most common complication of inguinal hernia repair. Basically, all this is rubbish. Rubbish. जरूरत ही नहीं है. You put this prompt on ChatGPT, make a clinical question. They make questions like this and they come in the exam because they like. Last line gives you the answer. Question, sab dikhaya yaar. Question, everything is given. He is having pain, everything is given. Most common complication, chronic pain persisting for more than 3 months. So I put this question because I didn't want you to be intimidated by reading long questions. बहुत सारा चीज दिखेगा घबरा जाओगे. Oh shit, oh shit, oh shit. Let that not happen. Okay. This is a PYQ. Lady was incidentally diagnosed with a 0.5 centimeter mass in her gallbladder. It is immobile, diagnosed as a polyp. She is asymptomatic. What is the next step? It will be reassured. If the polyp is more than 1 centimeter or patient's age is more than 50 years, or there are also stones with polyp, only then you will do cholecystectomy. Asymptomatic incidental polyps, nothing is to be done. It is not pre-malignant. These are pre-malignant. The ones that I have enlisted, these are the pre-malignants. Okay. Again, one of your favorite things. With surgery, if so, lap cholecystectomy. Lap chole. 61-year-old man with unstable angina complains of hematemesis after retching and vomiting. So what is happening? Vomiting, retching, hematemesis after binge drinking. So he is having what? Mallory stare. Endoscopy shows you the Mallory stare. It is not actively bleeding. What will you do? Expectant management. Okay, expectant management. Angiography with embolization will be done if endoscopy fails to control the bleed. Balloon tamponade obviously has no role here, no connection. This will be done if all other measures fail. Endoscopy fails, embolization fails, then you will think about this. Mallory stare is a submucosal bleed. Normally, nothing is required. It stops by itself. If it doesn't stop, you can do something. Okay, normally it stops by itself. Patient presents with renal colic. Urine analysis shows hematuria. There is a 1.5 centimeter stone in pelvis. Renal pelvis, eh? What is the most appropriate management? This will be lithotripsy. So 5 millimeter to 1 to 2 centimeter stone, ESW. Unless it's a hard stone or a lower calaceal stone. Jo yahan nahi diya, it is in the pelvis, it's not in the calicis. If anything else, PCNM. What is the diagnosis? Mallory stare endoscopy can do, yeah, you will do, but if it is bleeding, only then you will do something for it. Normally, by the time you do endoscopy, it is stopped. What is the imaging test? Ye test kya hai? Tests. What test is done? You are giving diagnosis. Excellent. This is IVU, intravenous urogram. You can see the kidneys. You can see the bladder. Agar bladder dikh raha hai na, so it is IVU. And you can see the kidneys, they are very close to each other. So this is a case of horseshoe kidney. And it is incidental. So you will do nothing. Okay. No need to do anything. This is incidental horseshoe kidney. Okay. Incorrect statement about the condition. Bowel is covered by 3 layers. This is true. This is omphalocele. So there are 3 layers covering the bowel: peritoneum, amnion, Wharton's jelly, frequently associated with syndromes. Why is this incorrect? Frequently associated with musculoskeletal. No, yeah, absolutely right. CVS are the most common abnormalities. What is this? We didn't discuss this before. What is this that you see? Kya cheez hai? With syndromes, there are many syndromes linked with the omphalocele. Many of them are there. So this is called as negative pressure wound therapy. Negative pressure wound therapy. Also called as VAC, VAC, vacuum assisted closure device. So negative pressure is given to the wound. It will suck out the fluid. It will reduce the edema. It will draw the wound edges together. It will promote granulation. So what it does, It promotes granulation. It's not minus 120 mm of Hg, not sure nahi, it is minus 125 mm of Hg. Okay, दो प्रेशर पता होने चाहिए, minus 125 here and 30 mm of Hg for pressure sore. ये दो प्रेशर पता होने चाहिए. बेड सोर के लिए 30 mm of Hg, नेगेटिव प्रेशर के लिए minus 125. These two numbers you should know. Important. This question will come in your exam. This will come. What syndrome is associated with these lips? So this is Peutz-Jeghers syndrome. Okay, remember in Peutz-Jeghers, you get hamartomas. Okay, it is non-neoplastic. You get hamartomas. STK11 mutation. Yeah. Favorite question? What is this? Goodsall rule applies to? It's not types of perineal abscess or drainage. It is prediction of course of tract, and it will also predict location of internal opening. You know why I've put this question na? Purposely. It will predict the location of internal opening by looking at the external opening. What is this classification of anatomical types of fistula? ये कौन सी classification है? What is this? Option C. Is there any such classification? I asked this question already. Yeah, that is Sparks classification. Wonderful. Okay, I think we are done. So we have covered all the PYQs, PYTs, new questions, old questions all together. Total कितने क्वेश्चन थे? 75 क्वेश्चन, 75 सर्जरी. कल का पेपर किसने बनाया? सर्जरी क्वेश्चंस आर माइन ओनली. ओके, सो डोंट वरी अबाउट इट. सर्जरी मैंने दी है, बाकी का पता नहीं है. सो okay, I hope you enjoyed the discussion. You spent many days with me, and I hope you got new things to learn. Hope your life has become easy. Shock will be covered in medicine. If it's not covered, you let me know. We will do it in one of the days. Okay. So all the best, guys. Have a good day. Please stay tuned for Sir's class. Now you will have dermatology. I don't know when it will be, but all the best, guys. Have a good day. Bye bye.